What are you thinking about when you're facing these patients in your urology clinic, Ken?
Well, one of the things is, I think bone health is really critical for all these men. Again, I think for a while it was overlooked what we're doing to these patients. We put them on ADT, we give them all these treatments, we just don't really do much for their bone health. So we actually have our own bone clinic that if you're on ADT and a patient like this would get an automatic referral, make sure they're getting calcium and vitamin D at optimal levels, and then either zoledronic acid or denosumab. So again, I think that's critical for his bone health. And then after that, again, I think it's also important to talk about either how do you treat that metastatic lesion. Again, in this setting where he's castrate resistant, we're very, very much prone to radium-223. We believe in it. The Alsimca trial was very good in these patients, and so we're trying to put as many patients on it as they can, just because it's just another tool in the toolbox to help treat these men earlier. And again, I think if you look at I think it was Campbell Tate's data about treating men with low volume bone mets, that was from I think 2014 British Journal, they just do better than when they have high volume bone mets. So again, I think everything we're doing is trying to move earlier and earlier into treating these patients. Treating the lowest volume of disease you can, I think, is better. So we're moving towards doing that as soon as possible.
Great. And from your perspective, Neil, what are you thinking as a urologist?
Well, the case is kind of interesting in that the testosterone level was in the high castrate range. EAU guidelines is they've come out rather boldly and said it should be less than 20. AUA, we haven't done that. I'm a believer that if you're going to institute ADT, lower is better. So I like the idea of getting below 20 and hovering around that 45 range is just barely castrate. That concerns me about this case. I'm curious, after he received his abiraterone, how was his testosterone level? I don't know if you have that information, but of course you'd like to see that really go down significantly, because as there's still circulating androgen that's stimulating the AR, is it coming from tumor? Is it coming from the adrenals? And theoretically, with the ABI, it's covering that. I mean, to Ken's point, I completely agree, that this is a really good opportunity to be thinking about a really active drug that has survival prolongation in the bone metastatic CRPC group with radium-223. There's no doubt. What we see so often is what our colleagues, I think, are in the US and other parts of the world, they do the switch, which is the ABI to ENZA, ENZA to ABI. There's probably a little bit better data that you'll get some efficacy going ABI to ENZA, really small percentage ENZA to ABI. Kim Chi's done beautiful work on that, the PLATO trial. And there's multiple retrospective and prospective trials that have really shown that it's quite a short-lived benefit, if at all. So you said it, why not go with a mechanism of action drug like radium-223? Then the question becomes, and we can talk about this, is, well, would you add in ENZA while you're giving the radium? Let's talk about some of the notions around concomitant therapy of an AR and radium versus sequencing and layering it, the effect on the bone compartment. And then also, this is an interesting case too for just the notion around genomic profiling, which I'm sure we'll want to talk about.